Infective endocarditis is a severe, rapidly moving infection of the heart valves that aggressively throws debris throughout the entire bloodstream. Because the presentation is so systemic, you can't rely on a single positive test to confirm it. Instead, you need a strict mathematical scoring system to piece together a high-stakes clinical picture. Clinicians use the Duke criteria to reach one of two specific thresholds. We are either aiming for definite endocarditis, meaning we are virtually certain the infection is seated in the heart, or possible endocarditis, meaning the clinical evidence is too strong to ignore. This diagram shows the exact mathematical formulas required. To hit the definite threshold, you need to prove two major criteria. If you only have one major criterion, you need three minor criteria, or 5 minor criteria reach definite status. For a possible diagnosis, the bar drops. You need just one major and one minor criterion. Or 3 minor criteria put endocarditis firmly on your radar. Knowing the math is straightforward. The clinical challenge is looking at a complex, sick patient and correctly categorizing their diverse presentation into these specific criteria. Let's start with the major criteria. These are divided into two clear categories: the organisms isolated from the blood and the damage captured on imaging scans. For microbiology to count as a major criterion, it requires isolating a typical endocarditis organism, like Staph aureus or viridin strep. But there is a catch. You must isolate it from multiple, separate blood cultures. A single positive draw will not meet this high standard. On the imaging side, the classic major criterion is an echocardiogram showing structural devastation. This usually means a visible vegetation clinging to a valve or a deep tissue abscess. This visual grouping reflects how the criteria were recently updated. While the echo remains central, CTA and FDG PET CT scans have been elevated. As of 2023, identifying an abscess or pseudoaneurysm on a CTA or abnormal metabolic activity around a valve on a PET scan carries the exact same diagnostic weight as an echo. Major criteria represent the highest level of diagnostic certainty. They provide direct evidence of an active, seated infection inside the cardiac structure. When direct evidence of the heart valve itself is inconclusive, you have to rely on the minor criteria. These fall into 5 categories: predisposing conditions like IV drug use, a fever over 38 degrees Celsius, vascular phenomena, immunologic phenomena, and minor microbiologic evidence. Keeping the vascular and immunologic skin manifestations separate is a common clinical hurdle. On the left side of the screen are vascular phenomena. This includes Janeway lesions. These are septic emboli, small pieces of infected debris that lodge in the palms and soles. Because they damage tissue without triggering a massive local immune response, they are completely painless. Contrast that with the right side, immunologic phenomena. Here we place Osler's nodes. These are immune complex depositions that form raised, tender nodules on the fleshy finger pulps. The memory hook here is simple. Janeway is just painless. Osler's are oh so painful. That immunologic column also catches other systemic immune complex reactions. This includes Roth spots in the retina and glomerulonephritis, which damages the kidneys. Individually, these minor criteria are fragments of a larger clinical picture, but collectively they track the systemic, downstream effects of the infection, building a strong circumstantial case when direct evidence is lacking. Now, let's apply these rules to a rapid clinical scenario. Analyze this case. A patient presents with a history of IV drug use. They have a fever of 38.5 degrees Celsius and painful nodules on their fingertips. The lab reports a single positive blood culture for Staph aureus. Pause the video now. Based on the math we covered, calculate whether this patient meets the criteria for definite endocarditis, possible endocarditis, or if the diagnosis is rejected. Memorizing the raw facts is only the first step. True clinical mastery comes from recognizing how specific nuances in the patient's history can pivot the entire diagnosis. Let's break this down step by step. First, the patient's history of IV drug use is a predisposing condition. That is one minor criterion. Their fever of 38.5 degrees meets the temperature threshold, giving us a second minor criterion. Next, we see painful nodules on the fingertips. Painful means Osler's nodes, which falls into the immunologic minor category. That makes 3. Finally, we address the microbiology requirement. Staph aureus is a typical, highly destructive endocarditis organism. However, the lab only drew a single positive culture. Because it lacks the required multiple draws from separate sets, it fails to meet the major threshold and is instead classified as a minor criterion. Tallying the checklist, we have exactly 4 minor criteria and 0 major criteria. Recall the formula. A definite diagnosis requires 5 minor criteria. With only 4, this patient strictly meets the threshold for possible endocarditis. This changes the clinical management, illustrating why paying strict attention to blood culture volume and timing is vital. This comprehensive summary chart organizes the entire 2023 update into a single view. Go ahead and screenshot this. It tracks your major organisms and imaging, including the new CTA and PET additions, against your 5 categories of minor criteria and the final scoring math. And remember the most frequently tested distinction. Osler is oh so painful and immunologic, while Janeway is just painless and vascular. Internalizing this framework gives you the systematic approach needed to navigate complex endocarditis cases, whether you are presenting on the wards or taking your board exams.